Dear colleagues, it's great pleasure to join Okutromena as a representative of Turkish Ophthalmological Association. I will talk on late anterior segment problems based on corneal problems. Usually these patients are sent for keratoplasty. However, the first thing we have to do is to decide whether to do keratoplasty or not to do. This patient is a woodcutter and he was sent from Cyprus for keratoplasty. However, he had ectopic pupil synechia stuck behind the corneal scar. After pupillary dilation, we saw that the visual acuity increased to 0.5. Thus, we decided not to do penetrating keratoplasty instead, because he was a woodcutter and retrauma is a great possibility. The inferior portion of the cornea is clear and he is coming from far away, which will cause difficulties in regular and emergent visits. And we decided to go on with optical sector iridectomy. As a first step, synechia were released. Sphincterotomies were not sufficient to cause pupillary opening, and we excised a tiny strip of iris along with pupillary margin. After the procedure, visual acuity improved to 0.7 and the patient didn't become dependent on a transplant clinic. This is a pediatric patient who was also sent for penetrating keratoplasty, also from far away city. And we decided not to do keratoplasty, even there was a vertical scar passing through central cornea, because graft survival is lower in children. Children are prone to repeated trauma, and trauma resistance is decreased significantly after PK, and he's coming from distant city. After Yamani scleral fixation IOL implantation, we sutured the iris tear to form a pupillary opening. After the procedure, visual acuity improved to 0.4 from this clear area, and the patient without being dependent on a transplant clinic. This is an adult alcohol addict patient with fixed dilated pupil and sulcus IOL. His visual acuity in the fellow eye was also very low. And we decided to proceed with keratoplasty. However, because the rejection rates are lower and suture-related complications like astigmatism, infection are decreased, and corticosteroid needs is also decreased, and relatively glaucoma incidence is also low in lamellar grafts. But we need a strong barrier between anterior and posterior segments in order to keep the graft in the anterior chamber. We have to decrease the pupillary opening, the pupillary diameter, to keep the graft in the anterior chamber by using modified Sipser's knot. After simultaneous pupilloplasty and DMEC surgery, with functional graft and clear cornea, visual acuity reached to 0.7. When there is a scleral fixation, the barrier is lost and there is a gap between anterior and posterior segment, which we must recreate this barrier. And we proceed with, we have to decrease the pupillary diameter. I prefer 2 stitches for this. I don't prefer circlage because iris trauma is less pigment and less inflammatory cytokines are released, and it's quicker. After simultaneous pupilloplasty and DMEC surgery, visual acuity improved to 0.2 because of chronic macular edema. You see the two iris sutures. When there is aphakia, the barrier is lost totally, the barrier is absent. We have to implant an IOL. We have to fixate it to ocular structures and correct the iris defect. Fortunately, there was a sulcus and we implanted IOL in the sulcus and sutured the iris tear. After sequential DMEC surgery, visual acuity improved to 0.8 with functional graft, clear cornea with a fairly round pupil. When there is no sulcus, we have to create it. We have to fixate the IOL to the ocular structures, and we proceed with the modified Yamani technique. We introduce the needle into the eye, insert the haptics into the needle, and externalize them. We proceed with DMEC surgery. We do desmothoraxis over an air bubble because the transparency and visibility is high, and remove it. Inject the graft into the anterior chamber, open it with indirect maneuvers, and attach it to the cornea with air or some kind of gas. After simultaneous scleral fixation, pupilloplasty, and DMEC surgery, visual acuity improved to 0.5 with fairly round pupil and functional grafts. This patient is similar to the other, however, he had a very large area of synechia, and we thought that we won't be able to create a sufficient iris diaphragm to keep the DMEC graft in the anterior chamber, and we decided to go on with penetrating grafts. First, the synechia are released. And we insert the needles before the penetration of the eye, and externalize them by moving the needle parallel to the sclera, parallel to the limbus. We do the same to the other haptic, externalize it by moving the needle parallel to the limbus. And we cauterize the haptics. We can correct the iris diaphragm. We can repair it as an open sky procedure. It's easier than closed procedures. And after the operation of triple procedure, you see a transparent graft, penetrating graft, and a fairly good iris reconstruction. When patients have a corneal, additional significant scar in addition to corneal edema, we decide to proceed with penetrating grafting. This patient also had a fairly large area of iris defect, nearly 180 degrees, and we decided to go on with sequential surgeries. Cataract surgery needed CTR implantation because of the zonular defects of the superior quadrant. There is a glass foreign body remaining in the eye from the previous accident, car accident. PK is done as a separate surgery. And after sequential surgery, iris were left unrepaired and visual acuity improved to 0.2. This is a nice similar eye with a total aneurysm. We have to proceed with penetrating graft. We have an IOL with an iris prosthesis. We suture the eyelids of the haptics, tie the sutures, and this IOL is very large and we need a very large scleral incision. It's very traumatic. I think the most traumatic surgeries in my life. And we externalized the sutures, implanted. This patient needed 2 regrafting because first graft had a primary graft failure. This is a covered technique. We remove the previous graft under the new one. And the last picture is the end of the case. This patient also had total aneurysm with graft edema and significant scar. These are the placement of Yamani IOL point fixations. We try to not to penetrate the eye. Accidentally, a full thickness penetration occurs, and we suture it because we need a tight eye to penetrate the needles into the eye. When the eye is hypotonic, it's very difficult. First, we put the needles and then we remove the cornea. This was my first Yamani case. This is my safety suture because I'm not a vitreoretinal surgeon. I want to drop the IOL deep into the vitreous. I'm pulling perpendicular the needle. It's wrong. We have to externalize it by a maneuver parallel to the sclera, not perpendicular to the ocular tissues. It moves like arrow shows the correct moving direction. Although with total aneurysm, grafts functioned well for 4 years with a fairly good visual acuity. When we face with a patient with corneal edema in addition to corneal scar, we have to decide whether to do keratoplasty or not to do. When we decide to go on with keratoplasty, we have to decide whether to perform a penetrating graft or lamellar graft. In order to do DMEC, we have to create a barrier between anterior and posterior segments, sufficient barrier, by implanting an IOL and decreasing pupillary size, and to complete the case with successful DMEC surgery. Thank you for your attention.